Hello everyone, welcome to podcast 20 of Let's Revise MBBS, and our today's topic is maternal pelvis. Okay, so pelvis is formed by three main bones. Posteriorly we have sacrum and coccyx, and anteriorly we have three bones, that is a combination of three bones, that is ilium, ischium and pubis. So these together form the pelvis. Now in pelvis we have true pelvis and false pelvis, and there is a pelvic brim which separates these two pelvis. So pelvic brim separates true pelvis from false pelvis. So anything below pelvic brim is true pelvis and above pelvic brim is the false pelvis. Now the pelvic brim is formed by anteriorly there is pubic crest, then we have pubic tubercle, then superior ramus, then we have you can say iliopectineal line, then the ala of sacrum, and finally posteriorly there is sacral promontory. So this forms the pelvic brim. Okay, so we are concerned about the true pelvis, whatever is below pelvic brim. Okay, false pelvis is not of much importance here in obstetrics. Okay, so now talking about true pelvis we divide it into three parts: inlet, cavity and outlet. Okay, so pelvic brim forms the inlet, cavity is from the below the pelvic brim up to the ischial spine, and outlet is below that. Okay, so in each part, in inlet, cavity and outlet, we have three borders, three diameters: anteroposterior, oblique and transverse. But what is important to us is which is the shortest one, right? In all these three parts, in inlet, cavity and outlet, we will mainly focus on the shortest diameters. Okay, because if the baby's head passes this diameter, then it can pass any other diameter also. Okay, so let's first talk about inlet. Now inlet is at the pelvic brim and we have three diameters there. But the important one is the antero-posterior diameter. Okay, so in antero-posterior diameter, we again have three conjugates: true conjugate, obstetric conjugate and diagonal conjugate. So let's see. So the pelvic brim, okay, when we saw the border or boundaries of the pelvic brim, posteriorly there was sacral promontory, okay, and anteriorly there is pubis. Now pubic symphysis, if you divide the pubic symphysis in three parts, uppermost, middle and lowermost. Okay, draw a line from imagine a line from uppermost part to the sacral promontory, then middle part to sacral promontory, and then lowermost part to sacral promontory. Okay, imagine these three lines. Now the topmost line is known as true conjugate, from top of the pubic symphysis to the sacral promontory is true conjugate. Okay, from middle part to the sacral promontory is obstetric conjugate, and from the lowermost part to the sacral promontory is diagonal conjugate. Okay, I'll tell you the measurements of each of them. True conjugate is 11 centimeters, obstetric conjugate is 10.5 centimeters, and diagonal conjugate is 12 centimeters. Right, so which is the smallest one? Obstetric conjugate. Okay, obstetric conjugate is the smallest one. So we are concerned with obstetric conjugate. But the problem is we cannot directly measure obstetric conjugate by clinical pelvimetry. What we can measure or what we can approximately measure is the diagonal conjugate. Okay, so the rule is diagonal conjugate minus 1.5 is equal to obstetric conjugate. So here we saw diagonal conjugate is 12 and obstetric conjugate is 10.5. Okay, right. So this was about the anteroposterior diameter. Oblique and transverse diameter for inlet is not required because they are adequate. Now let's talk about the cavity. Cavity, we have two planes there. Like we have many planes, but two main planes of concern. One plane is from S to S3, the junction of S to S3 to pubic symphysis. So this plane is of the greatest diameter. So that's not important for us because the diameters are big. From S2, S3 to pubic symphysis, they are enough for baby's head to pass. But the diameter of shortest diameter, the plane of shortest diameter is between between the two spines. Okay, so interspinous diameter is the shortest diameter in the cavity. Okay, interspinous distance is 10 centimeters. Okay, this is about the cavity. Now in outlet, the limiting or the shortest diameter is the transverse diameter, which is between the two tuberosities. Okay, in cavity also, shortest diameter was transverse diameter between two ischial spines, and here in the outlet, the shortest diameter is also transverse diameter, which is between the two ischial tuberosities. It measures 11 centimeters. Okay, so finally you need to remember three diameters: obstetric conjugate 10.5 centimeter, interspinous diameter 10 centimeter, and bituberous distance or bituberous diameter 11 centimeter. Okay, everything is normal. Now when do we say that the pelvis is contracted? Okay, again we'll talk about these three diameters. So if obstetric conjugate is less than 10 centimeters, or if interspinous diameter is less than 8 centimeters, or intertuberous diameter less than 8 centimeters. Okay, if this is the case, then we call it as a case of contracted pelvis. Okay, so how will you measure interspinous distance? You insert your two fingers, index and middle finger, in the cervix and spread them apart and see whether your two fingers touch both the spines or not. If they are touching, that means interspinous distance is not enough. Okay, and for intertuberous distance, what you do is you put all your four knuckles in the cervix, okay, and see whether they are easily fitting or not. If there is some resistance, if they are not fitting easily, that means again the intertuberous ligament is not sufficient. Okay, so if this is the case, then we call it a case of contracted pelvis, and for contracted pelvis we need to go for C-section. Okay, now let's talk about CPD, cephalopelvic disproportion. So CPD can be either due to problem in cephalus, that is head of the baby, if the baby is macrosomic, for example born out of diabetic mother, okay, or for some other cause he is macrosomic, or C, we talked about C, and P, pelvic. So if there is contracted pelvis or pelvis is very short, very narrow, okay, so in any of the two cases CPD can occur. Now CPD is difficult to diagnose because it can happen that the pelvis is normal in size, but still there is CPD. This can occur if the fetus is too large. Okay, so it's difficult to diagnose. Since, as we saw contracted pelvis, it's easy to diagnose. Clinically, we can measure the diameters and we can diagnose if it's contracted pelvis or not. But that's not the case with CPD. So to diagnose CPD, the best way is to give the trial of labor. Okay, we will try giving her labor, and if she delivers normally, then it was not a case of CPD. If there is obstructed labor, then it might be CPD. Okay, so this is the best method, that give a trial of labor. Now let's talk about VBAC, vaginal birth after cesarean section. Okay, so C-section can be of two types, upper segment, lower segment. Nowadays we generally do lower segment, but in some cases if we are required to do upper segment, then the risk of rupture in VBAC, like in vaginal delivery after upper segment C-section, is higher. So once the female has undergone upper section cesarean section, then we avoid VBAC. Okay, vaginal birth after cesarean, we avoid it in the upper segment C-section. But if the previous C-section was lower segment C-section, then we go for vaginal birth after C-section. Okay, because the risk is quite low in LSCS, risk of rupture. Okay, now let's talk about VBAC in detail. So in which all conditions can we do vaginal birth after C-section. So if the pelvis is adequate, if the fetus is normal, there is no malpresentation, and previously she should have LSA should have been done maximum 2 times, not more than that. Okay, so if these conditions are met, then we can go for VBAC. Okay, now if we are giving a trial of vaginal delivery after cesarean section, then we need to mainly monitor 2 things. First is labor, which we normally also do in any vaginal delivery. But second important thing is we need to monitor the scar, the earlier scar of C-section. Okay, so for monitoring labor, you monitor it on partogram and you specifically shorten the second stage of labor. Okay, by instruments or by forceps. Okay, so you manage labor accordingly. We'll talk about management of labor in further podcasts. And to monitor scar, every 30 minutes you need to monitor the scar. So there can be 2 possibilities. There is impending scar rupture or there is scar rupture. So impending scar rupture is scar is about to get ruptured, and other case possible is it can get ruptured. So how will we understand that the scar is impending rupture is there? So there are certain signs and symptoms. If there is maternal tachycardia, abnormal fetal heart rate, scar tenderness, if you touch it, there's a lot of pain, scar tenderness. Okay, so if you see these conditions, then that's the case of impending scar rupture, and then you immediately take her for LSCS. Okay, so this was for impending rupture. If the scar ruptures, then what are the signs? Obviously there will be heavy bleeding, she'll be in shock, fetus will be in distress, and most important is there will be loss of station. So we have talked about inlet, cavity and outlet. So inlet is given station -5. Okay, at the ischial spines it's station 0, and at the outlet it's station +5. So -5 to +5, there are various stations. Okay, so if initially your judgment is that the station is +2, okay, and then there is a rupture of scar, so what will happen is the station will be lost, the head will be floating, right? So this is one of the specific finding of scar rupture, loss of station. Okay, so how will you manage this? You need to immediately resuscitate the mother. You need to give insert 2 large IV bore cannula and give her fluids, and then immediately take her for laparotomy. After taking her for laparotomy, we need to repair the uterus if we can, and if it's not possible, then we need to do hysterectomy. Okay, now let's talk about the last topic, that is types of pelvis. So there is a classification which is Caldwell and Mohoy classification. According to this, we have 4 main types of pelvis, which is gynecoid, anthropoid, android and platypeloid. Okay, so as the name suggests, gynecoid is the female pelvis, which is normally present in most of the females. So most common will be gynecoid pelvis. Anthropoid is ape-like pelvis. It is second most common. Okay, so around 50% is gynecoid, 25% is anthropoid. Next is android. Android is male-like pelvis, so it is present in 20%. And platypeloid is a flat pelvis, and it is very rare. Okay, so most roomy pelvis will be gynecoid pelvis. Okay, so let's talk about side walls. So side walls, if you see, they'll be parallel in gynecoid as well as anthropoid, but in android they will be converging. The side walls will be converging, and in platypeloid the side walls will be diverging. This we will understand in a better manner if we see the shape. If you see the shape of gynecoid pelvis, it is transversely oval. Okay, transversely oval, and anthropoid is longitudinally oval. It's like egg shaped. So in both these cases, side walls will be straight because they are oval. The android pelvis is heart shaped. Okay, the anterior portion is the apex of the heart, so the walls will be converging. Okay, and the platypeloid is bowl shaped. Okay, now most common outcome of pregnancy in gynecoid pregnancy is normal delivery. The position will be occipito anterior, or it will be in the anterior quadrant, okay, in the gynecoid pelvis. In anthropoid pelvis, which is the ape-like pelvis, the most common outcome is face to pubis delivery. That the face will directly face the pubis. That means the position is occipito posterior. Okay, direct occipito posterior. So yesterday I was talking about 12 o'clock and 6 o'clock. So at 12 o'clock, it's not just occipito anterior, it's direct occipito anterior. And at 6 o'clock, which is posteriorly, it is direct occipito posterior. Okay. The most common outcome in android pelvis is deep transverse arrest. Since the spinous process of the ischium, the ischial spines are quite sharp and prominent in android pelvis. Deep transverse arrest is common in android pelvis. The head will not be able to go below two spines, because already the interspinous distance was less, and in android pelvis the spines are even more prominent. And the most common outcome in platypelloid type is floating head. Okay. Now there are other two rare types of pelvis. One is Naegeli's pelvis and the other one is Robert's pelvis. So in Naegeli's, it's N. N means the first is 1. First line resembles 1. The vertical line of N resembles 1. So in Naegeli's pelvis, one ala of sacrum is absent. And in Robert's pelvis, there is R. So R has 2 in it, if you can see. So in Robert's pelvis, two alas are absent. Okay. So in Naegeli's, one ala of sacrum is absent, and in Robert's, 2 ala of sacrum are absent. Okay. So yeah, so that's it about maternal pelvis. So we'll meet in tomorrow's podcast. Till then, enjoy and keep studying. Bye bye.